Welcome to today's webinar, From Heart Rate to Digestion, Autonomic Nervous System Function in People with Down Syndrome. Thank you for joining us. My name is Laura Crone, and I'm the Project Manager for Research and Education at the Advocate Medical Group Adult Down Syndrome Center in Park Ridge, Illinois, which is a suburb of Chicago. Next slide, please. We are a clinic for adolescents and adults with Down syndrome ages 12 and older. Since opening in 1992, our healthcare professionals have seen over 6,000 individuals with Down syndrome. Our team includes physicians, an occupational therapist, a licensed clinical social worker, patient advocates, and numerous support staff who serve the physical, mental, and social health needs of individuals with Down syndrome. In addition to providing patient care, we offer a variety of research and education opportunities such as this webinar and our online resource library. Next slide, please. Our redesigned online library launched last week, and it contains nearly 500 articles, visuals, videos, and other resources related to health and well-being of individuals with Down syndrome. You can access it free of charge at adultdownsyndrome.org or by using the QR code on the screen. Next slide, please. Before I introduce Dr. Chicoine, I have a few reminders. This webinar is being recorded, and the link to the recording and the slides from the webinar will be emailed to attendees within 1 week. There will be a Q&A at the end of the presentation. Please feel welcome to submit questions throughout the webinar using the Q&A option. We will address as many of them as we can. Additionally, if you requested a certificate of attendance, you will receive an email with the certificate within 1 week if you attend this webinar live. Next slide, please. Our presenter today is Dr. Brian Chicoine. He is the co-founder and medical director of the Adult Down Syndrome Center. He is also on the faculty of the Family Medicine Residency at Advocate Lutheran General Hospital. In the interest of time, I'm going to share his full bio in the chat. Thank you all for being here, and with that, I am going to turn it over to Dr. Chicoine.
Thank you, Laura, and welcome everybody. Good to be here with you today. So we'll jump right in. A lot of good information, I think. Hopefully you'll find this helpful. So what we're going to try to do today is we're going to give a general overview of what the autonomic nervous system is, explain some differences as we know them in people with Down syndrome, and then describe how it impacts various organ systems, and then symptomatically what you might see with that. So first, what is the autonomic nervous system? So to take a step back, the nervous system in general, as you probably know, is in a sense the body's command center that sends messages back and forth between the brain and other parts of the body. And it's typically divided into the central nervous system and the peripheral nervous system. So the central nervous system we think of primarily as the brain, and to some degree the spinal cord, but then the peripheral nervous system is definitely the nerves that go out into the various parts of the body and connect with various organs. And that peripheral nervous system is made up of two subtypes. One is the somatic nervous system, and that's the part of the nervous system we think about. So if I want my left arm to move, my brain says move the left arm, and the nerve and the path, the signal goes down the nerves to that my left arm, and then my left arm moves. So that would be the part of the nervous system we more actively think about, and we have more active control over. And conversely, it would be if I touch something hot, that I get the feedback from that nervous system as well. And then the autonomic nervous system is the part of the nervous system that is that we tend not to have to think about as much, or it acts automatically. And so this does not require our active thought processes. There are some ways that you can have a little more control over the autonomic nervous system, but not typically in the same way that we would think of as with the other parts of the nervous system. So the autonomic nervous system controls a wide variety of functions: heart rate and blood pressure, digestion, urinary function, temperature regulation, and many other things. And typically the autonomic nervous system, so with the skeletal nervous system, with other part of the nervous system, it goes to what are called skeletal muscles. So the muscles like in our arms or our legs, and so that part of the nervous system controls those. But with the autonomic nervous system, it tends more to go to the smooth muscles that are like in the intestines or in the uh, uh, in the bladder, things like that. And so it focuses more on function of those parts of the body. The autonomic nervous system also goes to the heart, and so we don't enter the blood vessels. So we don't typically think of needing to. I don't say I want my heart to beat at 60 beats a minute. Now there are some people that have incredible control over that, but most of us don't. And so my heart rate functions pretty independently of my active thinking about the heart rate. And so those would be the things that happen more automatically and are referred to as the autonomic nervous system. So to go a little further, there are two parts of the autonomic nervous system that are recognized, and one is the sympathetic nervous system, and the other is the parasympathetic nervous system. So in the sympathetic nervous system is sometimes described as the fight or flight part of the nervous system. So when it's activated, you see something fearful or there's danger, your heart's going to beat faster, your blood pressure rises, your sweating increases, your digestive function decreases, and typically more blood flows to the muscles so that you're ready to fight or flight. Where the parasympathetic nervous system tends to be more the rest and digest part of the nervous system. And so when that's activated, our heart rate tends to beat slower, our blood pressure decreases, our sweating decreases, but our digestive system, the digestive function increases. And so after we've eaten a meal, much of our body kind of calms down and the digestive system kicks in and increases starts to work overtime, if you will, and is more active to address the digestive process. So those are the two different parts of the autonomic nervous system that we typically talk about. So how is the autonomic nervous system different in people with Down syndrome? So in people with Down syndrome, oftentimes it's been looked at that people with Down syndrome have reduced sympathetic, so this reduced fight or flight, and then increased parasympathetic, so more rest and digest. However, actually some studies report the opposite. So I think as it's become more clear that it's less clear. So it is more complicated than just the sympathetic always being reduced and the parasympathetic always being increased. So it really, there's more to it. There appears to be more to it than that. And so it's not just as simple as that. And part of this is that other factors in body functions complicate the differences in organ function. So, what we would think would be perhaps driven by the parasympathetic nervous system, and so causing more contraction of an organ, for example, we may actually see that it's less, and some of that may be that we know that there are differences in collagen, the connective tissue, the tissue that holds us together. So maybe that's not as strong as it might be in somebody else, and so the organ is not able to contract as well. We also know that people with Down syndrome tend to have lower tone in their skeletal muscles, and oftentimes that's true for the smooth muscle as well. So again, even if the autonomic nervous system was telling a particular organ to contract, perhaps the smooth muscle did not have the same contractility or the same strength, if you will, as somebody without Down syndrome. And so you might not get the same effect. And then it's also clear that different times of the day or different activities, sleep versus awake, activity versus rest, and those can have different impacts on the sympathetic and parasympathetic activity. And so again, it does make it a little more complicated, or a little more challenging to know exactly which part of the autonomic nervous system is increased or decreased. And again, so not as simple as perhaps once thought. And the other thing that actually makes it even a little more complicated is that it's clear that in some organs, there's differences in the number of nerve cells in the organ. So, particularly parts of the bowel, for example, a person without Down syndrome may have, X number of nerve cells per centimeter, and a person with Down syndrome may have less. And so then even if the autonomic nervous system was overall functioning at the same level, the ultimate effect, because of the less nerve cells, might be that the function is reduced. So again, just one more layer of complexity to this, that there's just not a simple answer necessarily that on the autonomic nervous system function. Long and short of it, more research is needed, and to continue to help us learn, what the implication, what the differences are and what those implications are. So how do these autonomic nervous system differences affect various organ systems of people with Down syndrome? Now, notice I say differences. And so it's not always dysfunction. Sometimes it's, in a sense, dysfunctional because things it ends up creating symptoms or health issues. But sometimes it's just different and really does not negatively affect the individual for the most part. So I'm going to use the term differences rather than dysfunction. So before I jump to the different organ systems, first thing I just wanted, just as a general, I'll talk about treatment for each of the conditions or each of the organ systems. I just wanted to sort of a general rule of thumb for the treatment at this point. We don't really have treatment specifically for differences in the autonomic nervous system. So, way to turn up or turn down the parts of the nervous system. But there are treatments for the effects caused by the differences in the autonomic nervous system. And so, in a sense, we're in a sense treating the symptoms, more than the underlying differences in the autonomic nervous system. But that's basically the limits of what we're able to do at this point in time. More time over the years, we may find, that changes. But in the meantime, more study is needed to better understand the autonomic nervous system and what more directed treatments might look like and how they would be implemented in people with Down syndrome, or any of us for that matter. So the first one we want to talk about is blood pressure. So as you probably know, blood pressure is typically a one number over another, So, it might be 120 over 80 or 135 over 85 or whatever the case. So the upper number is what's called the systolic blood pressure. And the lower number is called the diastolic blood pressure. And in a way to think of it, the systolic blood pressure is basically when the heart is pumping. So that pushes the blood pressure up. And then the heart relaxes to refill with more blood, getting ready for the next pump. And so in between there, the blood pressure drops a little bit, and that would be the diastolic blood pressure. So that's basically in between beats, and that happens 60, 70, 80 or more times in a minute, up and down. In people with Down syndrome, both of those numbers, both the systolic and diastolic, tend to be lower than in people without Down syndrome. So a normal, a typical blood pressure in people without Down syndrome is considered 120 over 80, although there's certainly a range in various people. And there is, an upper level that's considered too high, and then is considered hypertension or elevated blood pressure. But 120 over 80 is sort of a typically recognized normal blood pressure in a person without Down syndrome. For people without Down syndrome, it's often lower. And so we've often seen people in the office or in the hospital with the blood pressure of 90 to 100 systolic and maybe 60 to 70 diastolic. And there is still significant variation in that as well in people with Down syndrome. So those are just sort of rough average guides, if you will. So we've certainly seen people that have lower blood pressures than that and do very well. And we've certainly seen people with higher blood pressures as well. Interestingly, we see very little hypertension or very little high blood pressure, what would be considered high blood pressure in the rest of the population. So not only do people down tend to have lower blood pressures, they also tend not to have hypertension, the elevated, blood pressure that's concerning for heart and other long-term complications. So what are the symptoms of low blood pressure? So again, if a person with Down syndrome is walking around with a blood pressure of 90 over 60, and doing fine, we're not concerned by that. But if they're at that blood pressure or lower, and they're regularly getting dizzy or fainting or having significant fatigue, we want to probably take a look at that and see, is that blood pressure too low for that person? And does that need some attention? And then also the other issue is what's called orthostatic hypotension. And what that is basically when you go from lying to sitting or standing, or from sitting to standing, does your blood pressure drop? And does it drop to a point where you get dizzy or faint and pass out? And that would be called orthostatic hypotension. So there are kind of specific guidelines for people without Down syndrome. If the blood pressure drops a certain amount and the pulse goes up a certain amount, which would be a common reaction of the body to try to raise that blood pressure, to increase the heart rate and try to get that blood pressure to get back up so the brain is getting enough blood. And so there are specific guidelines for that. They've not really been used the same ones for everyone else, but that's not really been standardized in people with Down syndrome, to my knowledge. But clearly, the big issue would be symptoms. And so, not so much the absolute blood pressure values, but is the person having these symptoms, and is the person actually also having them symptoms when they stand or when they go from sitting or lying to sitting? And so those would be important things to look at, and with regards to is that blood pressure that's lower in the person with Down syndrome, is it significant clinically? Is it causing problems? And that's an important question to ask. The other additional considerations would be, one is it's important to know a person's typical blood pressure. So this certainly comes up in the hospital on a regular basis. So someone comes in and they're sick and they have an infection. And sometimes one of the complications of an infection is that our blood pressure can drop. And so, if your typical blood pressure for you or for me is 130 over 80, let's say, and I'm in the hospital and my blood pressure is 130 over 80, doesn't look like I'm having a negative effect of that infection on my blood pressure. But if my blood pressure is 80 over 40, that's a significant change from my usual blood pressure. That certainly needs attention. Similarly, in someone with Down syndrome, let's say their typical blood pressure is 90 over 60. They get admitted to the hospital and someone contacts me and says, we're concerned about their blood pressure. And so I go back and I look in the chart and I see, he's been in the office, 5 times in the last 3 years, and his blood pressure was always 90 over 60. So I'm not as concerned that the infection is causing a drop in blood pressure if it's 90 over 60. Now, again, conversely, just like anyone else, if now it's 70 over 30, that's definitely a change, and that's something we want to take note of and consider needing treatment. Certainly in anesthesia is another place where the blood pressure might be an issue. So we know that in anesthesia, some anesthetics can cause the blood pressure to drop. So again, at what point is that too low and starting to cause problems? And that's certainly something that the anesthesiologists are aware of or are becoming aware of, that's an important issue, again, to know what the typical blood pressure of that person is and to monitor for any changes, not only in the blood pressure, but in the effects of a lower blood pressure. The other thing that we have found that people with Down syndrome can be sensitive to developing symptoms with anything that further reduces the blood pressure. So, if your blood pressure is typically 120 over 80, and you can tolerate pretty easily down to 110 or 90 over 60, I'm just making that up, but just as an example, it may take a lot more to get that blood pressure to go down. But if your blood pressure is already pretty low, as it is in some people with Down syndrome, sometimes they don't have as much wiggle room between what they can tolerate and what they can't. So if they get the infection, as I mentioned, or their heart rate goes down, or they're dehydrated, they're not drinking enough fluids, or they've lost fluids because it's hot, or whatever the case may be, or they're afraid, which can can cause our blood pressure to drop at times. It does seem that some people with Down syndrome then are more sensitive to those changes, and then there can be more of a concern with fainting or getting dizzy. So how do we address this blood pressure issue? Not dissimilar from the rest of us, from other people. We want to make sure we're drinking plenty of fluids. Different than many of the rest of us who are being cognizant that our blood pressure may be getting too high. For many people with Down syndrome, we want to consider that salt intake may be needed to keep the blood pressure up. I have seen many times in our practice somebody with a person with Down syndrome present who is having some difficulty with the blood pressure being down a little further than usual, having some dizziness. And as I talked to the family, it discovered that somebody else in the family has developed high blood pressure. And so the whole family has started to cut back on salt in their diet, which is an appropriate management tool for an elevated blood pressure. But our patient with Down syndrome doesn't have the high blood pressure, and in fact, they already tend to be on the little lower side. And so when they drop out that salt, their blood pressure drops even further. And now they're having dizziness. So the person with the high blood pressure is now it's got a normal blood pressure, and our patient with Down syndrome has a too low blood pressure, and so is developing symptoms. So considering for some of our patients, people with Down syndrome, they do have to consider salt intake. Some of the folks we see will place some saltine crackers and a glass of water next to their bed, and first thing in the morning before they get out of bed, they drink the water and they eat the saltine crackers, and that helps them manage that situation where their blood pressure tends to drop, particularly after they've been sleep all night and not drinking, obviously. Getting up slowly from lying or sitting can be very important, and this is certainly an issue that helps any of us have less dizziness if we're tending towards our blood pressure not responding as quickly when we get up. Sometimes compression garments, compression stockings, for example, can help the blood flow back to the heart and can increase the help the blood pressure maintain and not drop so low. We have a nice article on our resource library on compression stockings. Some individuals need medications like midodrine or droxidopa, which can help elevate the blood pressure. And then as we're looking at this, one of the things we always want to ask, is this related to the heart rate? And is it because the heart rate is lower? So in general, the heart rate of people with Down syndrome does tend to be lower than other people. So people without Down syndrome, what's considered a normal pulse or a normal blood pressure is 60 to 100 beats per minute. And in people with Down syndrome, it's not uncommon to be in the low 60s or even in the 50s, occasionally, particularly if they're at rest or sleeping, and maybe down even into the 40s and doing fine with that, with no symptoms and no problems. The other thing is we see that some people with Down syndrome, when there are situations where an elevated heart rate is expected and beneficial. So if you get anesthesia and it causes your blood pressure to drop a little bit, your heart should compensate by increasing the rate that it beats to try to increase the blood flow. Or if you're exercising, it would be expected that your heart rate would go up to pump more blood to the muscles and other parts of the body so that your brain continues to get enough blood as well. And sometimes people with Down syndrome, they don't have that, or that response is muted or decreased compared to other people. And so that can cause some challenges. So what are the symptoms of a low heart rate, also called bradycardia? Similar to the low blood pressure, it would be dizziness, fainting. And oftentimes, if you've ever had a situation where you're started to get dizzy because you felt like your heart rate was going down because you were in a fearful or painful situation, oftentimes we'll sweat as well. We're going to talk about sweating here in just a minute, but many people with Down syndrome tend to sweat less anyway, so we may not see that as a symptom in this case where the heart rate is going down significantly. What are some additional considerations? So again, just like with the blood pressure, many people with Down syndrome seem to be more susceptible to factors that decrease the heart rate, such as pain, fear, and dehydration. So again, they may have a little less of a safe window, if you will, between, this blood pressure, they're okay, or this pulse, they're okay, this heart rate, they're okay. And it goes down a little bit, and now they're not okay, where someone else might have a larger window where they would still be okay with it, even though it went down. And so that seems to be the case in some people with Down syndrome, where it drops a little bit and then they develop symptoms quicker than someone else might. The other thing that's interesting is that there are studies that look at formulas for determining target heart rate in exercise. So if you've ever had what they call an exercise prescription, so it's recommended you exercise X number of minutes a day at a moderate heart rate elevation. And so let me just give you an example. So a 40-year-old person without Down syndrome, by using the formula that is used in people without Down syndrome, it would be 220 minus the person's age, so that's 180. And then moderate exercise would be about 70% of that. So 70% of 180 is 126. Uh, if you look at the person with Down syndrome with this modified formula, that same 40-year-old, the maximum instead of being 180 would be 157, and then 70% would be 110 instead of the 126 for somebody else. So the target heart rate for exercise, based on the physiology of the heart and the tendency towards a lower heart rate to start with, then reduces those numbers. That doesn't mean the person with Down syndrome isn't working as hard. It means actually their increase in their heart rate may be similar to somebody else, but it may be coming, instead of coming from 70, it may be coming from 50. And so 110, this elevation to 110 is still a significant and beneficial increase in the heart rate. So that's just one consideration with regards to exercise. So, he's only got his heart rate up to 110. He's not pushing very hard. No, he may be pushing just as hard as somebody else who's up at 126. And so, that's an important consideration for when we're looking at people exercising and how much to encourage them to work harder. And then people with Down syndrome also do seem to be susceptible to more rhythm disturbances. So we know that's clear in people with Down syndrome who had a history of congenital heart disease. So as they get into adulthood, particularly, they may have more difficulty with abnormal rhythms. There's also some data now that shows that this is probably true, maybe not quite as often, but maybe it seems to be as true for people without congenital heart disease as well. So rhythm disturbances are an important thing to consider. So again, where is the line between, that heart rate of 50 is okay, versus that heart rate of 50 is abnormal, or that heart rate of 20 or 30 is clearly abnormal. So, looking at, are these clearly rhythm disturbances? Are these just part of who the person is? And a good chunk of that is, are they having symptoms? And what's the effect on their heart function? So those are the things that all have to be kind of taken into consideration. But I think the reason I bring this up is that we do want to, although we're saying, this is typical for a person with Down syndrome, if it's going too low and they're having symptoms, we do want to make sure we're not looking for some significant abnormal. We do want to make sure we are looking for some significant abnormal rhythm possibilities that we don't want to overlook, because that can be real problematic if those are overlooked. So how do we manage the heart rate and pulse to help maintain it? So by and large, we're looking at treating the low blood pressure, as we talked about, management for low blood pressure. And then when it goes really low, those abnormally low and people are having symptoms and we're not able to bring it back up, that may be a place where a pacemaker would be appropriate. And a pacemaker is surgically implanted, and a lead goes to the heart. And if the heart rate goes too low, pacemaker does not allow the heart rate to go below a certain predetermined level that's programmed into the pacemaker. And then if we look at blood pressure and pulse, what is one of the things we're concerned about? And one of them would be fainting. And so one of the things with fainting is called vasovagal syncope. And people with Down syndrome seem to be more at risk for this. And so what this is that the blood pressure and the heart rate may drop in this situation. And again, people with Down syndrome seem to have a increased sensitivity and response to stimuli that lower the heart rate and blood pressure. So again, things like fear, anxiety, pain. We all probably seen or even ourselves had the situation where get into a painful situation, and the next thing you know, our heart rate drops in response to that, and now we're getting dizzy on top of it, or it's a very frightening situation, and our heart rate and blood pressure drop, and then we pass out. And so that's not unusual for any of us, but it does seem to be more common, and probably people with Down syndrome do tend to have this increased sensitivity to these stimuli. Interestingly enough, we posted recently on our Facebook page about psychogenic non-epileptic seizures. So these, in the past, they've been called fake seizures. That term is not used anymore. What they are basically is that someone looks like they're having a seizure, but if you put an EEG on them, they put the leads on their head and looked at the electroencephalogram, they're not having any seizure activity in their brain. And so there does seem to be a component of this that is psychological. But it is interesting that sometimes people will have changes in the autonomic nervous system function when these are happening. And so they're again, the psychological system, our psychology may actually then be affecting the autonomic nervous system such that the blood pressure may drop or the heart rate may drop. So a lot of interaction with these different situations. So again, what's the management? And basically the same management as for blood pressure and the heart rate or pulse. Obviously avoiding scary and painful situations. Obviously, there's limited control that we have over that, obviously. And then a sort of a similar but different condition is called postural orthostatic tachycardia syndrome, often called POTS. And in this, it's interesting, different than orthostatic hypotension. We talked about orthostatic hypotension. The person stands up, and their blood pressure goes down. And oftentimes, again, we would hope that their pulse goes up to try to prevent the blood pressure from going down. But in POTS, the blood pressure remains the same, so they don't have the drop in the blood pressure, but the heart rate actually goes up quite significantly. So, and this tends to be sustained for some a period of time, and by definition, it's increased. The heart rate increases by more, about 30 beats or more per minute. So, if the person's walking around with a heartbeat of 60, they stand up and their pulse races up to 90 or 100 without the change in the blood pressure. And interestingly, so it's again, the blood pressure is not dropping. So, but the symptoms are not terribly dissimilar than with the other conditions we talked about. So again, dizziness, palpitations, meaning the sensation of the heart beating differently or abnormally, lightheadedness, fatigue. Some people complain of brain fog. They may have tremors, blurred vision, may have a exercise intolerance, and other symptoms as well. And interestingly, the onset is frequently precipitated by a viral infection, surgery, prolonged bed rest, and others. So not necessarily each episode, but something happened, and then people start to get these things on a more regular basis. Interestingly, it may be less common in people with Down syndrome because what we talked about, the heart rate tends to be lower and tends to go up less in response to these things. So there's some sense that this may be less common in people with Down syndrome. Certainly saying it doesn't say, I'm not saying it doesn't exist, but it may be less common. And the management, again, not necessarily at the time of the event, but regular exercise seems to help reset the nervous system and reset the cardiac system in a sense. Good fluid and salt intake, as we mentioned for the others. And again, the compression garments, the compression stockings can all be helpful. And there are a variety of subtypes. Some of it does seem to be affected by the autonomic neuropathy. Some of it seems to be more endocrine based, the norepinephrine or noradrenaline. And some of it is related to low blood volume and other subtypes. So again, not aware that I could not find much information real specifically about this in people with Down syndrome, but certainly I've known of people who with Down syndrome who have had this. Next topic is acrocyanosis. So acrocyanosis is a discoloration of the hands and feet. In white or fair-skinned people, it tends to be more bluish. In darker-skinned people, sometimes it's a color change, but it may not be blue. It may become dark. The skin may become darker, or it may not really be noticeable at all. And so this can be a little more difficult to diagnose in someone with darker skin. It's caused by constriction of the small blood vessels. So for any of us, if we go outside in the cold or we're chilly or whatever, the little blood vessels in our extremities particularly, but elsewhere in the body as well, they constrict, they get smaller. So it's diverting blood flow away from the skin to try to keep our core, to keep our to keep us warm, and it's done at the expense of the extremities. For the most part, unless the prolonged situation, it tends to be painless. Again, it's a normal response to cold temperatures. And so we see a lot of folks with Down syndrome that really it's not so cold. It's not so cold out, and they do have the situation. So that it does seem to be, in a sense, exaggerated in some people with Down syndrome compared to others who would only see it when it's significantly cold out. And again, there's some to be this greater sensitivity of people with Down syndrome. It can contribute to dry skin, and I'm pretty convinced that it contributes to dry skin in some people, and then the dry skin tends to make the skin, perhaps more red or discolored, and so it seems to feed on itself. The acrocyanosis, the more dry skin, it makes the acrocyanosis look worse, etc. It is different than Raynaud's. Raynaud's is a condition which is often autoimmune, which we do know that autoimmune disease, where the body's immune system attacks other parts of the body, we do know that those are more common in people with Down syndrome. So Raynaud's can be autoimmune, but Raynaud's tends to be episodic, and this is vasospasm or constriction of bigger arteries, different than the acrocyanosis, which tends to be smaller little blood vessels. And these clamp down in Raynaud's, and oftentimes there's paleness followed by cyanosis or blueness or color changes noted above, and then typically followed by redness, which occurs during the rewarming. Oftentimes there's numbness, pins and needles, and pain, which is typically different than acrocyanosis. What is the management for acrocyanosis? Basically, keep the extremities warm. Wear a hat when you're outside in the winter, and good again because it contributes to dry skin, and some people good skin care. For most people, it's not it's not leading to anything. It's not going to cause problems down the road, perhaps other than the dry skin issue. And so it's not a terrible concern about if you're not treating it, but it does seem to help. Perhaps with the skin and help people have less problems there. So similarly to the acrocyanosis is the issue of temperature regulation. And this is really interesting. And in general, we found one study that found that the body temperature of women with Down syndrome was about 2 to 3 degrees Fahrenheit lower, and the body temperature of men with Down syndrome was about 2 to 2.5 degrees lower in people with Down syndrome compared to people without. And in our experience, I would say probably closer to 1 degree, but certainly more in some individuals that it tends to be lower. Again, most people seem to tolerate that just fine. But one of the times we really begin to think about is if a person has an infection where we might expect them to have a fever, the elevation in the temperature from starting at a lower point may not be what we would typically consider a fever in somebody else. So fever may not be as reliable a sign or reliable of indicator of infection as it would be in somebody else. Interesting, some individuals with Down syndrome report less tolerance to the cold, so they get cold more easily. But some also report not feeling cold even when the not feeling cold even when the temperature is cold. So they're outside in the winter in shorts, and so it seems to be not a one size fits all situation for people with Down syndrome. But definitely some temperature difference in temperature regulation seems to be an issue for at least some people with Down syndrome. How do we manage that? So certainly one of the ways we can help with temperature regulation is make sure we're well hydrated. If we're getting dehydrated, in long runs, someone's out there exercising a long period of time and they get dehydrated, they can either get very hot or very cold, depending on how dehydrated they are. And so for any of us, and so good hydration helps maintain a body temperature better. When there's concern that there might be an infection, we want to make sure we're looking for other signs of infection and not just relying on the temperature and say, oh, his temperature is normal, he doesn't have an infection. That may not be as accurate in people with Down syndrome as it might be in somebody else. And then monitor for the need for weather appropriate clothing. So again, the gentleman with Down syndrome goes outside in the winter and in his shorts. I know other people who don't have Down syndrome who do that and do just fine. They just seem to have no problem with that. But certainly, if the person with Down syndrome is having difficulty with having skin problems or heaven forbid frostbite from that, obviously those are things that we're going to want to obviously going outside without shoes on in the winter is probably not appropriate. And that's we'd want to take a look at that, even if they're not complaining that they're cold. And then the other question is with regards to the need for clothing is what is the contribution of sweating? So some people with Down syndrome seem to sweat less, and that can contribute to overheating. And And I always tell the story. I first became aware of this. I was running a 5K many years, you know, a run, a 5K kilometer run with one of our patients years ago, and it was a turkey trot, and it was November, and it was probably 20 degrees in Chicago, and so he came dutifully dressed in 5 layers of clothing, and which was appropriate for the weather, and by mile two, I was carrying three of his layers of clothing because he was overheating, and I looked over and I'm drenched in sweat, and he's not sweating. And so that really was the first time I really began to think about, do people with Down syndrome, do they sweat the same as other people? And the answer is at least some do not. Now, whenever we post this on the Facebook and share this, inevitably someone would say, oh, my son sweats like crazy, or my daughter sweats a lot. This isn't one size fits all, but definitely some individuals sweat less. And so that can be a concern with overheating, particularly in hot weather or with exercise. So good hydration, again, monitor the need for weather appropriate clothing. In some of these individuals may not need as many layers as someone else. If they are getting overheated, using cool compresses to help them cool off because they don't have the sweating mechanism to help cool them off. And some people just need to limit exercise in very hot or humid conditions, which again is not unusual for any of us, but to consider. But for some individuals with Down syndrome, that may be more of a consideration. And now let's go to the gastrointestinal tract. Now, last year we'd given a webinar on gastrointestinal conditions, stomach, esophagus, intestine, etc. And I think it was the only webinar I've done that for the clinic that we ended up doing 2 parts, because there are just so many gastrointestinal issues in people with Down syndrome. And so what is the role of the autonomic nervous system in these conditions? There are other reasons for conditions in the gastrointestinal tract, but the autonomic nervous system does seem to contribute in at least some of them. So one of the things is motility. How does food and waste, how does it move from the mouth to the anus? How does it go through there? And one of the things is the gastrointestinal system contracts and pushes these substances through the body, and then at times there are at different junctures there are valves that close and prevent the food from going backwards. For example, from the stomach back up into the esophagus after we eat. So how does that motility? And so this is typically slower in people with Down syndrome, and at least some of that is probably related to the autonomic nervous system. And the slow motility can contribute to constipation, gastroesophageal reflux disease, again, food and acid coming up out of the stomach back up into the esophagus, also called GERD or heartburn. And then swallowing dysfunction is also more common in people with Down syndrome, and the effect of the autonomic nervous system probably affects that as well. So some of it may be a possible imbalance between the parasympathetic and the sympathetic nervous system. Some of it may be a discoordination. So again, with the sphincter at the bottom of the esophagus going at the stomach, does that close at the right time? Does it close too early? Does it close too late? Is it open when it should be closed? So some of it may be a discoordination. In some situations, as I mentioned before, there may be a decrease in the number of nerve cells in parts of the gastrointestinal tract. And again, the difference is in collagen, the connective tissue. If the tissue just isn't as strong, it may not be able to push, even if the autonomic nervous system, as I mentioned, is pushing or is telling to push, it may not have the same push. And similarly with the low tone of the smooth muscle. There's so much to the management of this. Decided not to try to address that here. But again, we do have that 2-part webinar series that we did last year on the gastrointestinal health. I encourage you to take a look at it if you'd like further information. Autonomic nervous system also does affect our metabolism, and we know that metabolism, people with Down syndrome, can be different in some situations. So the autonomic nervous system affects how we metabolize glucose or sugar or lipids or fats, how much energy is expended, how much insulin is secreted, the feedback we get from the nutrients we consume. So we eat something, does the body tell us, I've had enough? And that's probably different in people with Down syndrome in some situations and others. So We do know that the autonomic nervous system and metabolic differences are both found more commonly in people with Down syndrome, and the link between the two certainly needs further study, and how that might help with the management of those things. And then I want to getting close here to time. I want to leave some time for questions, but urinary retention is something we see more commonly in people with Down syndrome. So the inability to empty one's urinary bladder. And their symptoms or complications may be difficulty starting the stream. They may develop bladder infections, contribute to kidney damage, urinary incontinence. All this is not unique to people with Down syndrome, but does seem to be more common in people with Down syndrome. And again, this whole issue of discoordination, but in this case, between the bladder contractions, the muscle of the bladder contracting, trying to expel the urine, and does the sphincter, which is preventing the urine from leaking when we don't want to urine to be leaking, is there a discoordination? So is the bladder contracting, the sphincter is not relaxing? And again, that's one thing that the autonomic nervous system is involved in. But again, similarly with the connective tissue and the strength of the connective tissue, as well as the muscle tone, that can all contribute to this. One of the things we see, for lack of a better term, I'll call it a behavioral component. We do see some individuals with Down syndrome who tend to hold their urine for very long periods of time and seem to either not have a strong sense they need to go or choose not to go. And so that really stretches out the bladder, which can make this worse. So the management really depends on the cause. But one of the things, particularly for this issue of holding the urine, we recommend what we call time toileting, and that's using the bathroom every 2 to 3 hours. And some people will put timers on their watch or on their phone or whatever. That's just remind them to go every 2 to 3 hours. There are some medications, sometimes catheters are necessary, and sometimes surgery, depending on the cause. Interestingly, jumping to asthma, which is narrowing the airways that causes wheezing, this actually seems to be less common in people with Down syndrome. So a little unclear how the autonomic nervous system impacts on that. Some of it may be that people with Down syndrome seem to have less allergies than people without Down syndrome, and so that allergies can contribute to asthma. So that may be some of it, but I think this one is one of those things where it just seems a little more complicated than we can easily explain away on the autonomic nervous system. And then, what is the contribution of autoimmunity? So autoimmunity, again, are conditions in which the immune system attacks other parts of the body, causing dysfunction. Almost looks at that part of the body as an outsider. So it's attacking it just like it might attack a bacteria or a fungus or whatever. So it's attacking parts of the body as if it thinks it doesn't belong there. And we do know that autoimmune disease is more common in people with Down syndrome. And interestingly, it's now clear that the immune system can attack the autonomic nervous system. So there's a condition in the esophagus called achalasia, where there's, again, sort of this dysmotility where parts of the esophagus don't contract well, and the sphincter continues to contract, so food just has a hard time passing into the stomach. It's now clear also that the immune system can attack the heart, can attack the nerves, the pacemakers in the heart, the electrical system in the heart. And in people without Down syndrome, it's been shown in people with systemic lupus, something called Sjogren's syndrome, and also rheumatoid arthritis. And so this is an area that really needs some more study in people with Down syndrome, and what is the effect long-term on some of these heart rhythm issues in people with Down syndrome, and what is the effect of the immune system that may be contributing to that. So certainly the part of the treatment is to treat the resulting symptoms for whatever system is involved. How do we address that? But in the future, will we have more ability to prevent or treat this more from the immune system, really addressing it at the immune system level? More to come on that, but we definitely need some more study. So in wrap up, the autonomic nervous system function is different in people with Down syndrome. Not always a dysfunction, but sometimes just different. There is complexity and variability in the autonomic nervous system in people with Down syndrome. So it's not uniform across people with Down syndrome, what you might expect. I think the main thing that I would hope that you take away from this is be aware that this is potentially an issue, and then what can we do about it? If we don't even think about it, we're not going to be able to do anything about it. So be observant. Are there symptoms that might be related to this that are popping up that we want to know about? What can we do to prevent it? For example, if we know blood pressure and pulse tend to be lower, and people with Down tend to be more sensitive to further drop, let's make sure we're really working on daily hydration to help try to prevent that. And we do know also that the function and the effects may change over time. So in any of us, the autonomic nervous system function changes with aging. And we do know that people with Down syndrome have early aging. And so this may be something that occurs at a younger age. It also seems to be clear that Alzheimer's disease, which unfortunately is very common in people with Down syndrome, further impairs the autonomic nervous system function. And so that may be something to further consider. Any change in that function deserves evaluation and treatment. So we don't expect that, people are having symptoms or their blood pressure is really low and just say, that's just Down syndrome. No, we really want to make sure we're taking a look at that and seeing if there's an issue there. So lots of resources and references. This is, as Laura showed earlier, this is our new updated resource library. There's a number of references that you can link to on our page. To share with your healthcare professional, not only our website, but Care Down Syndrome is something that we are involved in, that is on, or we continue to be involved in, that the National Down Syndrome Society provides. It's really focuses on healthcare professionals. So please, please, please share this with your healthcare professional to help them be better informed on the care that they can provide, but also feel welcome to use it yourself. It's written for healthcare professionals, but it's certainly, you are very welcome to use it. It's all free. And please feel welcome to do that. And further, for healthcare professionals, feel if you're many families and people with Down syndrome have indicated that the healthcare professional is very interested in helping provide the care for their individual with Down syndrome, but they just feel like they need to know more. And so this would be another thing to share with them, the Down syndrome medical interest group, to share with your healthcare professional so he or she can better provide care. If you're interested in some of the primary references, we have them here. Oops. And we're going to stop for questions.
Thank you so much, Dr. Chicoine. So much great information. We're going to dive right into the questions so we can get to as many as we can. So the first question is, how does the autonomic nervous system relate to mental health? Given the differences in people with Down syndrome, are there any specific factors that should be considered?
Yeah, I don't think we know much about the specific effect of autonomic nervous system on mental health, but I think it's really clear that physical health change affects people, any of us, but particularly, we're talking about people with Down syndrome, affects people with Down syndrome. So if they're feeling dizzy from their blood pressure being lower, how does that affect them mentally? How are they worried about that? Does it cause them to feel uncomfortable? Are they not able to participate in activities, and that makes them feel, unhappy? So I think that certainly the indirect effect is very important. The other important piece is if we're looking to treat mental health, what are the implications with regards to the medications? Might they have, if someone's blood pressure or pulse tend to be lower, does that have an implication of what medication we might choose versus another that would not affect that, for example? And so I would say that at this point, I think the direct effect is still unknown, but I think certainly the indirect effect is great.
Thank you. Does the autonomic nervous system affect or control pain, and would you expect that to change as a person ages?
So, the pain tends to be, I would view the pain as being a little different system, but I think how our body responds to the pain certainly is impacted by the autonomic nervous system. And so that would certainly, how that changes over time certainly would affect. Just a quick aside, for a long time, it was felt like people with Down syndrome did not experience pain, but now that's really clear that that's not the case, that people with Down syndrome do experience pain. And at least in some situations, some studies, people with Down syndrome might actually experience more pain from a similar situation compared to somebody without Down syndrome. So people with Down syndrome clearly experience pain. And in our experience, with aging and with Alzheimer's disease, some people experience even a significantly greater amount of pain, so there's more autonomic dysfunction. There seems to be more dysfunction in the pain perception as people get older and develop Alzheimer's as well. So again, those are things we have to, again, this whole awareness thing, being aware that these things may occur is so important, so that we just don't, kind of sweep it under the rug and say that's not a problem.
Thank you. You talked about urinary retention. Is there an effect on the kidneys specifically?
Yeah, so really, not that I'm aware of. There is some differences in kidney function in people with Down syndrome, but the best, and there isn't a lot of literature on the kidneys and Down syndrome, which is interesting. But what we have found so far suggests that perhaps people with Down syndrome have less kidney cells. Uh, so how many kidney cells are there per centimeter of kidney tissue, and that seems to be a lower number in people with Down syndrome. So that certainly can affect kidney function. But what we see more with the autonomic nervous system, at least what I've experienced with the people that we have seen, is that they develop difficulty emptying their bladder. And so the bladder gets larger and larger and more filled with urine. And so it ends up being some back pressure back up from the bladder up into the ureter, up into the kidney. And it puts pressure on the kidney and can actually damage the kidney further. So I would say that the biggest issue we've had with the autonomic nervous system function is that situation where there's back pressure, if you will. There is probably other factors in the autonomic nervous system and the kidneys, probably with the blood pressure and other things that, it's more complicated, and I think more studies needed. And there may be some information out there that I just haven't seen, but I'm not aware of anything specifically.
Thank you. What role does the autonomic nervous system play in obstructive sleep apnea, if at all?
Yeah, so things like muscle tone and things like that. We do know that people with Down syndrome who do more commonly have sleep apnea, and so the airways tend to collapse. And so and then how does the body respond once the oxygen is lower? How does the heart rate? What's the effect on the heart rate? What's the effect on the blood pressure? So all of that's all intertwined, and presumably there is a significant effect. Again, I think those are things that are ongoing study to try to really sort all that out.
Okay, thank you. How does do any of these considerations change for someone who has Down syndrome and autism?
Yeah, that's a great question, and I am not aware that there's an answer to that. There was a study done a while back looking at health conditions of people with Down syndrome and autism, but I don't recall any of it that I would say would really jumped out at me that the autonomic nervous system is more different.
Thank you.
That sounds like a recurrent theme, but more study needed on that as well.
Unfortunately, the case for so many things in Down syndrome, right? Can the autonomic nervous system affect menstruation?
Yeah, again, not that I'm specifically aware of, or not that I've specifically seen. I would think, again, probably more the situation where how does menstruation and the symptoms of menstruation, how does that impact the individual, and what is the role of the autonomic nervous service system? I just always think of one of the many years ago, one of the things that really got me interested in the autonomic nervous system. Again, this has nothing to do with menstruation, but a similar situation. So we had an individual that was fainting on a regular basis. And so we began to look into that. There wasn't any structural heart problems, no heart rhythm, real abnormal heart rhythms. And as we began to piece it together, the person was having cramping in their abdomen. And as we pieced it together more, we ended up finding that the person had celiac disease. So ultimately, we went from fainting to celiac disease, and treating the celiac disease reduced the cramping, which reduced the fainting. So similarly, if a woman with Down syndrome is having menstrual discomfort or having a little bit of a lower blood volume related to the bleeding, what are the implications with regards to that in the autonomic nervous system? So I think at this point, that would be sort of the understanding that I'm aware of how that might be intertwined or interact. But again, I think there's, as we learn more, there may be more issues that we're not aware of at the moment, or that I'm not aware of.
Thank you. We've received several questions about GLP-1s, and I know that wasn't one of the topics discussed today. Are there any resources you would like to point people to?
Yeah, there is, on the Down Syndrome Medical Interest Group website, there was a webinar given near the end of last year about medications for obesity. So I would encourage you to take a look at that. I think that you might find that helpful. We are planning on, we have some information on medications on our website as well, written format, but it needs to be updated. And we do have particularly a couple of physicians that are really interested in this. And so we are anticipating that one of them, as well as Dr. Verma, the physician, and Dr. Frank, our occupational therapist, we're anticipating that they will be doing a webinar more on weight management later in the year and this year, and certainly Dr. Verma will focus on the medications as well.
Thank you. Oh goodness, we could go for another hour with all the questions we've gotten. Unfortunately, we're going to have to end the webinar for today, but we do have a lot more information on our resource library, so please feel welcome to check that out, and feel welcome to share the webinar recording, which will be emailed to you within a week. The slides will be included with that, and we're able to offer these webinars free of charge through the generosity of our donors. And if you'd like to support our research and education program, please see our giving page that it is linked there and is available at the QR code. Thank you all so much for joining us, and we hope you'll join us at a future webinar.
Thank you very much.